Hi, this is Brian Kim. I want to share with you this case of a patient who was referred to me. This patient had a dislocated Tecnis Z9002 silicone IOL. And so the decision is, can I use this lens or do I have to remove and exchange this lens? Because this patient has a Tecnis three-piece lens, I'm able to do the Yamane technique with this lens as opposed to a different lens. I think this lens is better for the Yamane as opposed to lassoing the haptic with the Gore-Tex suture. And so let's compare this lens, for example, with the Bausch & Lomb LI61 AO lens. This lens has PMMA haptics, which are also brittle like the Tecnis lens. However, look at how acute the curvature of the haptic is. This is more like a C-shaped curvature. Because of that C-shaped curvature, if you manipulate that PMMA haptic, it's going to be more prone to breaking. And because you actually have to straighten out the haptic, it will cause little torsion to the haptic, some stress to the haptic, and as a result can cause it to break or kink. Now, if you compare this to the Alcon MA60 AC lens, it has a similar C-shaped curvature to that haptic as well, which is just as limiting as the Bausch & Lomb lens. But this Alcon lens is even made worse because look how short that haptic is compared to the Bausch & Lomb lens. The curvature is acute, but it doesn't go as far. For example, the haptic on the top of the screen here, it doesn't go all the way towards the left. It just stops short of the edge of the optic. Now you compare and contrast this with the Zeiss C2 Lucia 602 lens. Look at how further the superior haptic is leaning forward past the left edge of the optic of the lens. And also the C-shaped curvature is not as extreme with the C2 Lucia. However, it is still a C-shaped configuration. The difference is the C2 Lucia has the very strong polyvanillidine fluoride haptics. Now this finally gets me to the J&J Tecnis Z9002 lens, and it could be any of the three-piece lenses, including the acrylic lenses. Look how much of a curvature. It's not a C-shaped curvature, it is more like an L-shaped curvature. This lens is really the best PMMA lens for this technique, the Tecnis family as well as the Sensor family lens. So you can see this is a patient with a dislocated IOL. You can see that there's quite a bit of capsule support here. Even though it's not stable, the patient does have some good capsule remnants around the lens, even though there's an open PC with a dislocated lens. And so that's really advantageous to me in this situation because even though I'm doing the Yamane technique, this patient does have some level of capsule support, which will provide some long-term stability. So you can see I'm making my limbal marks and making sure they are 180 degrees apart. I'm using the cannula to help me do that. And then I'm marking 2.5 millimeters posterior to the limbus with a caliper in radial fashion on either side. You want to make sure the conjunctiva is dry, and then I'm using the tip of that cannula that's wetted with the ink, and I'm marking exactly 2.5 millimeters back in radial fashion. Once I make this mark, I'm making a mark 2 millimeters adjacent in an L-shaped configuration on each side. I'm making my paracentesis incisions now. I'm injecting some intracameral lidocaine and epinephrine, and then now some intracameral dispersive viscoelastic. You can see that this patient does have some amount of capsular bag support, only partial here, inferiorly in this case. So I'm making a supratemporal keratome incision. And then a contralateral limbal incision to externalize the leading haptic. Because the lens is already in the eye, I don't really have to make a large incision, and that was a 2.4 millimeter keratome incision. Microforceps are used to lift the leading haptic into the anterior chamber. And with a handshake technique, I'm externalizing the leading haptic. Again, this is the Kim modification of the Yamane technique. By externalizing the leading haptic, I'll be able to cannulate the trailing haptic much more easily with minimal trauma and stress on the haptics. And with a two-handed technique, I'm going to lift the trailing haptic up and then gently externalize the trailing haptic from the keratoma incision. I'm injecting some more dispersive viscoelastic to coat the corneal endothelium and push the lens back. And then I'm going to bend my needles. This is a 30 gauge thin-walled needle. I'm bending 9 millimeters from the tip for the right side needle, and then at the hub at the left side needle about 70 degrees, making sure the bevel will face the approach of the haptic. I'm grabbing the incision, tunneling 2 millimeters, and then diving in, holding the eye in a neutral position, making sure that I'm on top of the capsular bag. You can see this patient does have some peripheral capsular support, which is very helpful and advantageous in this case. I place the trailing haptic into the eye, and very carefully I'm able to dock the haptic on the bevel of the needle. Again, because this is not a C-shaped configuration to the haptic and more like an L-shaped configuration. Disengaging the needle from the syringe with the help of a hemostat, using microforceps to very carefully internalize the leading haptic, and then holding the eye again in the neutral position. I'm passing the needle through the sclera 2 millimeters and then diving in. As you can see here, I'm not using any infusion in this situation because the eye is filled with viscoelastic, and because the lens is already in the eye, I don't have to do as many gymnastics. There is some peripheral capsular bag here. I'm trying to maintain the capsular bag, and I'm placing the needle above the peripheral capsular bag. I go ahead and grasp the haptic, dock it on the bevel of the needle, and it goes ahead and internalizes quite nicely. I pull the needle out, and the haptic comes out as well, carefully grasping it and then cauterizing the tip. It is very easy to break or bend these haptics, so it's very important to apply just a gentle pressure. Do the same maneuver on the other side, and making sure not too much of the haptic comes out as I pull the needle out. It does cause some stress on the optic-haptic junction there. Once I cauterize the tip, I let go, and then I push the bulb flush to the sclera, making sure it's not externalized. And because I want to be efficient, I'm just going to go ahead and use INA. I bring the IOP way down from 60 something to around 30, and then quickly try to evacuate the viscoelastic from the anterior chamber, because the dispersive viscoelastic can be a challenge to remove. And once this is performed, I'm going to go ahead and do my vitrectomy, just making sure there's no vitreous in the anterior chamber or to the wounds. And this is through an anterior approach and not through a posterior approach. So again, in this case, because the lens was already there, and since the lens still had some capsular support and dislocated with an open PC, I was able to use viscoelastic to keep the vitreous back, and I didn't have to use the trocar. And I'm going with an anterior approach with the vitrectomy. Again, this is really a belt and suspenders approach. I really didn't feel like I saw any vitreous during the case. I go ahead and close my main incision, and I'm increasing the speed here. This is a 10-0 nylon suture, closing the main incision. I always like to close the main incision. Anytime the capsule bag is open, you never know. You can always have vitreous prolapse found post-op. I really don't want to deal with that, and so I make sure I get a nice and secure incision, and then I bury the knot. Now, if you see here, the IOL optic is actually underneath the posterior capsule inferiorly there. So what I'm doing is grabbing the optic-haptic junction and lifting that part of the optic anterior to the posterior capsule there. So now you'll see the lens is actually centered very nicely. You can see that the lens is above the posterior capsule, which is still intact inferiorly. The lens is well centered in good anatomic position. And again, this is the benefit of having the Tecnis lens or the Sensar lens, the J&J style lenses. I'm injecting some Myocol now to constrict the pupil, and then I'll inject some subconjunctival lidocaine and Ansef at the end of the case. So again, I didn't have any vitreous in this case. I was able to do this through a closed system. No need to go through with the pars plana with the vitrector. I was able to use viscoelastic to control the eyeball and keep it inflated. I was able to keep the eye in the neutral position as I passed my scleral needles. The advantage of having a dislocated IOL in the Tecnis and Sensor family is that the haptics are not C-shaped, they're more L-shaped, and because of that, it's much easier to cannulate the haptic through the needle for the Yamane technique. Because the PMMA haptics are still very brittle, doing this technique with the Kim modified technique by externalizing the leading haptic and going after the trailing haptic first is really a much more easy and straightforward way to do this technique. And as you can see, this patient had a really well-centered lens and the patient did very well. So I hope this was helpful to you, and I thank you for your attention.